Hello guys, let's enjoy Dr. Y's chest radiology. I'm Dr. Y, medical professor, chest radiologist, Seoul, Korea. Today we're gonna talk about the parapneumonic effusion, chest X-ray and CAT scan findings. Lesson 70. Let's go. The name, long name. Pneumonia with parapneumonic effusion is a type of pleural effusion that arises as a result of a pneumonia, mostly from the bacterial origin, or lung abscess, or infected bronchiectasis. The types or the stages of parapneumonic effusions are three. The first one is uncomplicated. The name implies very nice. Uncomplicated effusion is good with antibiotics only, and often the microbiology is not proved negative and usually reversible. Very good news. And stage B, complicated effusion. It's complicated. Usually gram staining positive and culture positive. pH is less than 7.2 and LDH level is usually more than tripled. And the latest stage, empyema, means collection of pus in pleural space. Also, we classify as three stages. It means evolution of the disease. 1. The early stage, exudative stage. This initial stage sees a buildup of fluid in the pleural space due to increased capillary permeability, often caused by inflammatory cytokines of pneumonia. Pleural fluid is typically clear and neutrophil dominancy. 2. Fibrinopurulent stage develops if initial effusion isn't properly managed. Fibrin clots and membranes form and leading into loculations or pockets in the pleural cavity. 3. The latest stage, organizing stage. If effusion persists, fibrin membranes transform into a thick, non-elastic peel, potentially trapping the lung and causing the respiratory dysfunction. The symptoms are like this. Number 1 is respiratory symptoms. Most common symptoms are cough, sputum, and chest pain, chest discomfort. And the systemic symptom is fever, chair. And 3rd, pleuritic chest pain, pricking pain. 4, the sepsis. Treatments are like these. First, ASAP, as soon as possible, quick. That's the most important thing. Early diagnosis, early treatment is the best treatment. Second, usually in the earlier stages, antibiotics only is good enough. And 3, if the pus is collected, drainage need, a pigtail catheter or chest tube are used. And then finally, the worst case means thoracotomy with decortication. Let's get into the thoracic imaging findings. Chest X-ray and CAT scan findings are like these. First, we can see pneumonia and pleural effusion, usually unilateral in distribution, asymmetric in distribution. Second, we see pleural effusion. If complicated, it can go into septation, loculation, and it means empyema. Chest CT contrast enhanced CT shows us pleural thickening, pleural location, and pleural contrast enhancement. There is a famous sign named split pleural sign. As the name implies, pleurae, visceral and parietal pleurae are splitted, divided. So we can see the thickened, separated pleura with contrast enhancement. good and subscribed. Thank you very much. Be healthy and happy. Let's get into the photos. First, stage 1 case, pneumonia with unilateral effusion. Young man on the left side. Chest PA shows us pleural effusion, not with clean meniscus sign, somewhat irregular thick density with disappearance of left hemidiaphragm. On the lateral film, we see thickened left major fissure and hazy increased density in the left lower lung zone with only one single diaphragm. Okay, yes, that's the right side diaphragm. That means we have pleural fluid on his left lower portion. This is parapneumonic effusion. His two CT films. On the left side, we see axial non-contrast CT. On the right side, lung window setting CT. His right lung is clear, very normal, very normal. On his left side, we see large amount of irregular margin-bordered fluid, pleural fluid, probably exudate, not translate, indicated by the white arrows. And the black arrow shows passive atelectasis of left lower lobe or pneumonic consolidation of left lower lobe. What happened to him 1 month later? On the right side, we see almost normal, clear, healthy chest X-ray of him. He was cured, reversed after adequate antibiotics treatment, ASAP as soon as possible. He was successful. Second person, middle-aged man. On his left side, what do we see? Left film is erect PA view and right film is left decubitus film. But the shadow, pleural fluid, does not change according to the position. That means it is loculated. It is thickened. There are many pockets of the pleural fluid. So that's stage 2. These are his axial and coronal contrast-enhanced CTs. White arrow shows loculated, pocketed pleural fluid, surrounded by thick pleural wall, and the black arrow shows collapsed lung, pneumonic consolidated lung. It's complicated effusion. This third case shows us what will happen if we do not hasten, if we hesitate for the diagnosis. On the left side, it is uncomplicated pneumonia with parapneumonic effusion, but it went to the right side shapes. That means loculated pleural fluid on the upper side in this erect PA view against the gravity law. That means the upper loculated fluid is loculated, pocketed, and complicated. These two axial CT images are at the same time of a previous slide of chest radiographs. On the left side, it is not so complicated. The fluid is usual and we see the right middle of pneumonia. But on the right side, the fibrin exudative stage, we see loculated pleural fluid with enhancing pleura. That means it is already complicated. These left two axial CT, contrast-enhanced CT images are same at the time of a previous slide of loculated period. Left one is a little more upper level and the middle one is lower level. These two images shows us beautiful but actually ugly multi-pocketed, multiloculated, thick pleural enhancement, progressed, complicated stage of parapneumonic effusion. On the right side, this chest radiograph shows us what happened after 1 month later. Somewhat air fluid level, somewhat loculated, and somewhat ugly looking, not normal looking results. Sometimes the disease progresses so fast, and so we're surprised. The first one shows us right lower lobe consolidation pneumonia. 2 days later, we see progression to right middle lobe, the pneumonia, with exudate pleural effusion on right lower side. And 2 more days later, we see large, multiloculated, complicated pleural effusion. Even if we have put the pigtail catheter, the drainage effect was not so successful. The white arrow indicates the right upper lobe consolidation of pneumonia. The results: large loculated pleural effusion of right middle and lower lung zone, more than chicken egg sized white density. The 2 black arrows indicate the split pleural sign, split visceral and parietal pleura, which means the white density, egg-like density, means empyema of pleural space. This left side axial contrast enhanced CT shows what split pleural sign is. The 2 yellow arrows showing us split visceral parietal pleura. That is split pleural sign. That means the fluid is in pleural location, not in location. The white arrow indicates the right middle lobe pneumonia. On your right side, 1 year later, we see the resolution of pleural empyema, but see the residual fibrosis of right middle lobe. This last case shows us what happened to the pleural space of chronic empyema, chronic tuberculous empyema. Chest radiograph shows many calcification, pleural calcification with shrunken left chest cage. On your right side, the coronal non-contrast enhanced CT shows us what happened to the chronic empyema. White arrow shows split pleural sign, and 2 black arrows show us visceral pleural and parietal pleural calcification. Parapneumonic effusion is finished now. How do you feel? Thank you for watching. See you soon. Your dad quit smoking? Oh, congratulations. Big job.